Senior Consultant and Head of the Department of Anesthesiology, Aster MIMS Hospital, Calicut, onto the stage. Since Dr. Binal is engaged in GS meeting, I request Dr. Biju from Travancore Medicity, who will be chairing this session.
Shall we start? See, I'm here as a replacement because the chairperson Binal is unavailable, and I'm not familiar with Dr. Kishore also. So I think straight away we'll go into the topic. Welcome, Kishore. We'll start.
Thank you. At the outset, let me thank the Wayanad Muppen's Medical College Department, our sister concern anyway. Aster, I've been at Calicut Aster. Thanks for asking me to talk on this aspect. Now, day surgeries, the topic is central neuronic cell block in day surgery. Basically, we'll look at what is the status of spinal anesthetics in day surgeries, and do we offer spinals for day cases, because very often the surgeon says that this is daycare surgery, so there should be no spinal, it's always BGA. So we'll see what's the status of spinal anesthetics in day surgery and what sort of what drugs are available for us for this particular thing. Now, if you look at worldwide, the number of cases being done as daycare or ambulatory surgery is hugely increasing. In the sense that up to 70% of cases in US are being done as day surgeries, and they are targeting more. They want to do more cases as daycare surgeries. They increase the percentage to 80-85% or even 90%, because basically they have huge pressure for inpatient beds, so they want to do majority of the cases as daycare surgeries. And the UK and Europe is somewhere around 40%. Again, they are also targeting to increase maximum. And in India, unfortunately, there are no official data regarding what is the number of procedures being done as daycare. Unofficially, it's pretty much low, it's around 20%. Now, daycare anesthetic technique is very important in the sense that you need to satisfy all these factors to have a successful daycare surgery outcome, because you need to have a rapid recovery, you need your good analgesia post-op, it will be pretty much minimal post-operative nausea, vomiting, and patient should be mobile and should void on his or her own before being discharged. So all its point towards what you want is a rapid discharge. So since its inception of the daycare practice, or historically, general anesthesia has been the technique of choice, basically because of its simplicity and overall acceptance. And with the advent of newer agents like propofol, desflurane, remifentanil, etc., it became much more popular. However, two things which were detrimental in discharging patients following GA were the postoperative pain and nausea, vomiting, which obviously associated with any general anesthetic. So these were sort of addressed by the practice of multimodal analysis and an aggressive antiemetic prophylaxis to a certain extent address this issue. If you look at ambulatory surgeries, the definition or what constitute ambulatory surgeries, in most places it is discharged shortly after surgery. But in the United States, any surgery up to 23 hours after surgery, they consider it as an ambulatory surgery, and beyond that it becomes an inpatient surgery. But we'll be focusing on what we should do in the first part, like probably we need to discharge the patient shortly after surgery. Now, if you look at regional anesthesia, why regional anesthesia became popular in inpatient surgeries? Because of its perceived advantages of good postoperative pain and reduced nausea and vomiting and increased alertness. These were the factors which are attracting regional anesthesia. So people also try to look at whether we can provide regional anesthetics in daycare surgery, mostly under spinal. But the role of spinals were quite limited in ambulatory surgery because we didn't have an ideal agent. Whichever agent we use for intrathecal anesthesia should have a rapid sensory and motor block, and they showed a predictable regression within the time frame. You have regressed the blocks within 1 or 2 hours, and obviously low incidence of adverse effects. So a drug fitting into these sort of characteristics were not available in the initial phase. What were available were lignocaine and bupivacaine. You know everything about lignocaine and bupivacaine. Lignocaine with this transient neurological symptoms happening with intrathecal lignocaine, they became unpopular, and I think it's not anymore recommended for intrathecal use. So, and obviously bupivacaine and its variant levobupivacaines were of limited utility because they are long duration surgeries. Now, with the advent of 2 new drugs or licensing of 2 drugs for intrathecal use made people look into whether spinals can be accommodated into a day care pattern. The hyperbaric 2% prilocaine and 1% 2-chlorprocaine. They were only recently licensed for intrathecal use. Look at lignocaine, it sort of fit into an ideal ambulatory surgery spinal drug because of its rapid onset of block and fast recovery. But the very transient neurological symptoms, which was very high incidence of transient neurological symptoms, made it no longer used for intrathecal use. The other drug was bupivacaine. You all know about the pharmacokinetic profile of bupivacaine, long duration surgeries. The block takes to come out at least 4 to 6 hours. So people tried to look at whether we could use some low dose bupivacaine for day surgery practice, like less than 10 milligram, less than 2 mLs. They did find that it does have a beneficial of having shorter time to void, but ended up having high failure rate. Actually tried for unilateral arthroscopy, low doses for arthroscopy surgery, but recovery still happens 3 to 4 blocks, 3 to 4 hours. You could use it for saddle blocks. Again, the recovery period is a bit variable. So it was never used that very much in day surgery practice. Now about prilocaine, prilocaine was available as a local anesthetic long time back. It has a faster onset of action, intermediate potency and duration, but it was never licensed for use for intrathecal. Later on the hyperbaric preparation came, which has much more faster onset and offset compared to the isobaric one. So it was studied and it reduced the time of voiding around, it is a 2% solution, so 40 milligrams. They found that it was adequate for lower limb surgeries lasting up to 90 minutes. And they could discharge the patients within 4 hours of after administration. So sort of fitting into day surgery practices nicely. Again, you must know that it's now not, even now it's not licensed for intrathecal use in US, but it is licensed in the UK last 2010 or some place. But it's not, I don't think it's available, the intrathecal preparation is available in India for us to use. But there are a lot of studies, comparative studies looking at prilocaine and with bupivacaine, and this is one study which actually looked at in low dose prilocaine with low dose bupivacaine. Bupivacaine was only given around 1.5 ml, I think, and you could see that the motor block regression happens pretty quickly with prilocaine. Around 86% of the patients had motor block full regression at 2 hours compared to only 27% in bupivacaine, and time to regression of sensory block to L4 was only 97 minutes in prilocaine group. So the concern about the block, residual block remaining, was actually addressed with the prilocaine, because you could find it's only 97 minutes. The other drug, which again an old drug, which was there in the practice for many things, but not used for intrathecal practices, intrathecally, very short duration. It's an amide local anesthetic, and it's metabolized by the pseudochlorinesterone. So it's very short acting, it's less protein bound, so very short acting. A rapid sensory block within 3 to 5 minutes. And the duration basically depends on the dose. How much dose you give, the duration depends on dose. So anything around 30 to 60 milligram will give you anesthesia up to 60 minutes of anesthesia. That's one problem with one of these. You could only use for very short surgeries. It's only up to 60 minutes. And you could get a block up to T10 to T12 if you give around 30 to 60 milligrams, that's around 3 to 6 mLs of the preparation. And the studies looked at discharge time is not prolonged compared to even GA, they compared with GA. And it was sort of a close to ideal ambulatory spinal drug, and it was licensed in 2013, and subsequently in US also it's licensed for use in 2017 onwards. Again, comparing intrathecal chlorprocaine with bupivacaine, they found that there is a similar onset of block is similar, and there's quick titillation block and early discharge when compared to again 150 versus 325 minutes. So those are the drugs which were available, new drug for intrathecal opioids. And what about the role of additives? We usually add additives to prolong the action or prolong the quality of action. These are all off-label indications actually. All the lipophilic opioids like fentanyl and sufentanil are commonly used. They do improve the quality of analgesia and extend the post-operative pain to a certain amount of time. But when you use these drugs, you should keep in mind the opioid-induced side effects of pruritus, which happens in around 70% of patients who have intrathecal opioids. Post-operative nausea, vomiting, and some amount of urinary retention. These are the side effects of opioid. So there's no recommendation in daycare practice to use them if you can get away with only local anesthetics like the short-acting procaine or chlorprocaine. If you want to add, you should keep in mind these pruritus and post-op and these side effects. The other drug which was clonidine, but with this side effects of bradycardia sedation, it's no longer recommended to use in at least in daycare settings. Now, what are the advantages of spinal anesthesia over GA in a daycare scenario? We all know that spinal anesthesia have reduced post-op pain to any patient, even if inpatient or in any inpatient surgery. So it does have a reduced post-op pain and low incidence of PONV because we use minimum amount of drugs. So these were the common reasons for delayed discharge. So these could be avoided if you use spinal anesthesia in daycare practice. The other advantage was some of these patients, group of patients with the inherent risk associated with general anesthetic in anesthetic these patients like older, sicker and more obese patients. These patients were excluded from daycare surgeries. But as I said in the initial slide, because they are targeting more and more to case to be done daycare. So use of spinal anesthesia or central neurosynaptic blockade allowed these groups to be included into ambulance, especially the COPD ones. We all know that spinal anesthesia at least have some, wherever possible, has some benefits in the short term when you use in COPDs, obesities, reflux patients, OISs, etc., etc., even elderly patients also. So these were the few good advantages pointing people to use to include patients for spinals in daycare surgery. Again, chlorprocaine versus intravenous for outpatient and arthroscopy. They found that fast recovery, discharge criteria, almost similar, not prolonged anyway. And one of the other thing, the patient satisfaction also was assessed, and more patients were uncomfortable after GA compared to the regional. So patients are more comfortable with regional or anesthetic. So what are the perceived disadvantages? There are some obvious disadvantages when you put in a spinals in a daycare surgery. The obvious concern was the delayed mobilization and discharge, which was always there was concern when you do spinal whether you will be able to discharge the person. But the advent of procaine and chlorprocaine to a large extent have addressed this issue. You need to have full return of sensory and motor function before discharging the patient. That's so. These drugs have helped in addressing the issue to a certain extent. The other one is a post-operative urinary retention. Spontaneous micturition is the last function to recover after a motor block. So you have to have the block coming very, very low down to S3 dermatome to have somebody voiding spontaneously. Now, having said that, there are some other factors also influence urinary retention, like this what surgery they had, and what the patient risk factors are also, especially the elderly who has urinary issues pre-operative also, they'll have retention. So, it's a multifactorial, but if you add on to that or spinal anesthetic also, that will be a problem. The procaine and chlorprocaine there are no reported cases with proportion of POR, and Prilocaine has lower incidence. You can use some strategies from outside, like not giving much fluids, like less than 500 ml in the surgery. Then you can ask the patient to void before coming to surgery. So those all will reduce the incidence of postoperative urinary retention. And again, now the present criteria of discharge doesn't mandate patients to void before sending home. There are centers which send the patient, especially high risk group patients who doesn't void with catheter and come back after 2 days. And the low risk group of patients, low risk in the sense low risk for urinary retention, those patients, they are, even if they don't void, they are sent home with instructions to come back if they don't have a problem within the next 12 hours to come back to the day surgery unit. It's not clearly visible, but this is some sort of flow chart. They look at the high risk group of patients, high risk group, if they look at the ultrasound and look at the residual volume, if they have more than 400 ml of residual urine, they catheterize and send them home. So the passing urine is not mandatory as of the criteria to send the patient home. Hypotension bradycardia happens in GA also, so it's not particularly very much concern. The other thing is a unique concern is a post-dural puncture headache, which is unique to spinal. There are some preventive strategies. Use small gauge pencil point needles. You can prevent, and I think you had a good lecture in the previous lecture, had detail about how to manage PDPH. So you should have protocol and guidelines in place if these complications happens. Epidural has similar advantage with spinal, but obviously there is a time delay in attaining surgical anesthesia and more regression of block, etc. So as a sole anesthetic, if you can get away with spinal, mostly daycare spinal would be beneficial. So looking at that, ambulatory surgical procedures are suited for spinal anesthesia. Only thing, you need to target the drug and dose depending on the what surgery and the area of surgery and time of surgery you're planning. This is a flow in one of the largest daycare units. You have a flow chart algorithm, a flow chart to decide upon what drug you give based on the time of surgery, level of block, etc., etc. And this is mostly only on prilocaine and chlorprocaine. Unfortunately, we did have chlorprocaine to a short period of time, but I understand that it's not available now also. But if you have these two drugs, you can perfectly do daycare surgeries under, wherever possible, under anesthesia and spinal anesthesia. So to sum up, ambulance surgeries can be performed effectively with spinal anesthesia. You need to have the right drug, right patient, right procedure. With the use of availability of prilocaine and chlorprocaine, the delayed mobilization, the postoperative urine are reduced. And if you want to, if you are converting a lot of your daycare surgeries into spinal anesthesia, you need to train all the personnel involved in. It's very fundamental to success, like the surgeons, the nurses, and all other involved in the day surgery unit has to be trained properly. And you should have guidelines and protocols in place, especially regarding supplementing analgesia in the postoperative period and managing headache and retention if at all that happens. You have some guidelines and protocols in place. If you have all this, it is all these things, if it is safe, spinal anesthesia and daycare surgery is safe, effective and economical also. There is a lot of cost factor also which I didn't touch upon because it is least expensive compared to general anesthesia and daycare surgery. Thank you. There are a lot of literature available on daycare surgery and the spinals in daycare surgery. This is British Association of Daycare Surgeons surgery, and they have a directory of procedures, what are procedures you can do. There is a good practical guide to how to incorporate spinal anesthetics into daycare surgery practice. Thank you.
Thank you, Dr. Kishore. Ambulatory surgeries are here to stay, especially in high volume centers and with the insurance concerns. And Dr. Kishore had tried his best to enlighten us in the most simplest way he could. Audience, any questions? If not, we'll wind up the session.
Thank you very much.
Thank you, sir. Now I request Dr. Biju to kindly felicitate Dr. Kishore. Now, I request Dr. Venugopal sir to kindly come to the stage to felicitate Dr. Biju.